Tonight, I'd like to welcome Sinead Collins from the Orchid Cancer Trust. Um, she's worked in cancer services for over 20 years and has a specialist interest in urology and penile cancer in particular. And during the 13 years at the Christie in Manchester, Sinead set up and developed nurse-led services for surgical cancer patients and was appointed as clinical teaching fellow at the University of Manchester. Supporting patients remains a passion, and Sinead headed up Maggie's Cancer Support Centre in Manchester for over 4 years before embarking on a project role as Greater Manchester Cancer Alliance, exploring the impact of COVID-19 on access to the psychological support for cancer patients. Tackling health inequalities sits at the core of her nursing values and led to a role in developing urgent care services in one of the most socially deprived areas in the UK. Sinead joined Orchid recently to lead a transformation project raising the profile of penile cancer in communities across the 4 nations. The project will create opportunities for peer-to-peer support for men with penile cancer and support the information needs of the healthcare professionals, and also to improve early diagnosis and rates for rare cancer. It is my great pleasure to invite Sinead to Midweek Matters this evening.
Well, that was very good. Almost as if I'd written it myself, which I did. Hi, everybody. Hello. Thank you for allowing me to come and present to you this evening. If you've got any questions at all, ask me. There's no such thing as a daft question. Just ask me in whatever way suits you as we go through this together. So the presentation that I'm going to do are around the 3 cancers that affect men. So if you're not a man and you're on this presentation, it doesn't mean that it's not going to be interesting to you, because you could share that information with the men that you know. So even though it's about men's cancers, the information is for everyone. So I'm going to start now. I'm going to share my screen and I'm going to talk about the 3 cancers. Some bits might be a bit highfalutin and a bit over the top in terms of info, and other things will probably feel just right. And hopefully together we'll be able to understand the things that I'm sharing with you tonight. So there are no awful photos or pictures or anything like that, and we're just going to talk it through. And I've just got 1 or 2 photographs of pleasant looking drawings and things like that to show you. So off we go. Okay, where is it? There it is. Okay, so you can all see my first slide?
Yeah.
Yeah, that's great. Okay, I'm just looking if I look to the side, it's because the screen on my left is bigger and I can read it more easily than my laptop, even with glasses on. So
Do
a little bit about,
you want to make it, Sinead, do you want to make it into the slideshow so it's full screen?
Just a sec. I'm not very used to Zoom, to be honest. So
That's okay.
I'll take your advice.
Yeah, if you go into slideshow at the top.
Yeah.
And then from the beginning.
There. How's that? I've got it on full screen here. Have you?
No.
No.
Try from the beginning again.
Okay. Oh, just a minute. Sorry, folks. It's a bit disappointing. I'm going to stop the share and then start the share.
Okay.
Because it looks perfectly right to me. On my screen, I'm seeing the full presentation as I would want to as a speaker. How about now? No.
I can just see you.
Bless you. No one needs that, do they, all the time? Hang on. Right, let's start again. How about that? Right, starting again. Where is my share one? Share. Right, we're sharing again. Oh, guys, what's happening now? I wish I'd left it alone.
I know, sorry.
It's all right. It's okay. Uh, um, right, can you see it now?
No.
Oh, I'm seeing it perfectly well. Okay, and it's timing me and everything. Right,
Oh.
I'm gonna come back out a
The
bit.
other alternative is you could email it to me and I could share it if you want.
No, I'm because and I'll just try again,
Yeah,
if I may,
of course.
just to get myself back where I want to be. There we go. Right. So I'm going to try again with share screen. Okay.
So
You should,
that's fine. We're not in the widescreen. I don't know. No, we're not in the widescreen. Um,
okay.
but it is
I'll
what it is.
try.
It's fine.
Okay. You folks watching the presentation, can you see what I'm showing you? Okay, thanks everyone.
Yeah.
Let's go
Let's
then.
go for it. Yeah.
Let's go for it. I'm gonna I'm gonna yeah, okay. So the Orchid Cancer Charity was set up in 1996, and it was set up by these two gentlemen you can see here. The one in the collar and tie, looking rather swish, is an oncologist who's now a professor of oncology. So a cancer doctor, a cancer expert. And this doctor did chemotherapy and radiotherapy, that type of cancer treatment. And the other gentleman is a patient called Colin. And Colin had cancer in his testicle back in the early 90s and hadn't realized there was anything wrong with himself. Didn't know that there was a problem because he didn't know what to look for. So when he found out that he had cancer of the testicle, he was devastated and he was quite poorly. And he worked together with that doctor. And I'm very happy to tell you that he was successfully treated. And most men with cancer of the testicle are successfully treated. But with all cancers, it's important to report them early on. If you're the slightest bit suspicious of something, let somebody know. So Colin is still fine. I saw him at the Christmas do. So, but at that time, he really didn't think it would go well for him, and it has done. So, to pay back the universe, he set up this charity so that we could share information with as many people as needed it. So, the first thing that I'm going to talk about is cancer of the prostate. So, there are 55,000 men were diagnosed with prostate cancer last year in the United Kingdom, and 12,000 people every year die of prostate cancer, sadly. It is the most common cancer in men in the UK, and in January, it was announced that it is the most common cancer in the UK between men or women. It used to be breast cancer, but now it's prostate cancer. So it is the most common cancer in the United Kingdom. In the general population, so everybody just walking around looking at society, it can happen to 1 in 8 men. So a table of 8 men, you can expect one of them to possibly get prostate cancer. But 80% of men survive 10 years, and that's considered excellent outcome. So that's an excellent outcome. So a table a table of 8 men, one of them may get cancer, and 80% of those with cancer with this cancer will do well. So what is the prostate gland and where is it? It's not something that we hear about every day. Sometimes in school they used to talk about reproduction, didn't they? And used to say, well, this is the lady's bits and these are the man's bits. But they didn't really go into the ins and outs really of all of it. So just to show you, in case you don't know, and why would you know, where the prostate gland is. So I've got an arrow pointing to it there. So if this is a sideways picture of a man, and we're looking sideways at a picture, we can see his penis there going, where the urine comes out. And then we follow the water passage all the way up to the bladder there. That's that sort of largest dome shape. And then just underneath, in between the two spaces where that arrow is the prostate gland. So that's where it is. So it's at the top of the penis, inside though, and underneath the bladder. And it sits as if it's a round donut with the water passage going through it. And so sometimes the first thing that you might notice that there's a problem with your prostate gland is that you're unusually in need of a wee more often. And that's because the prostate might be swelling and pressing on that little tube, and that tube keeps saying to you, you need a wee. And you think, well, I don't, because I've just had a wee. But your brain thinks you need one. So sometimes that can be a prostate cancer, and sometimes it can just be a swelling. That's not got cancer in it at all. But we need to look into that. So you need to find out. So I'll tell you a few more facts about it as well. And then when we bring all the information together, these are the bits that tell us whether or not you're at risk and what you can do about it. So here are some of the risk factors. The main risk factor that none of us can do anything about is age. So we can't do anything about our age. We can Botox the face as much as we want, but the internal organs are the age of the rest of us. So if you look at that graph, I'm not good with graphs, but if you're like me and you're not good with graphs, what I will tell you is the older you get as a man, the more likely you are to possibly get prostate cancer. So it tends to be a disease of older people. So usually people over 55 years of age. We do sometimes see it in younger people. We do. But in general, we see prostate cancer in older people. So that's the first risk factor that we need to remember. What's my age? And then there are a few more. So family history, that creates another risk. So if your father or brother or son has had prostate cancer, that doubles your risk right away. And if that person had prostate cancer before the age of 60, it increases it even more. So if your father, brother, or son had prostate cancer before the age of 60, you have an increased risk too. Another thing that can increase your risk is a mutation in the genes, in the DNA. Again, we can't do anything about that. So we call this particular gene BRCA, and that's its name written there, but they call it for short BRCA1 and BRCA2. And BRCA1 and BRCA2 are found in women who have breast cancer and ovarian cancer. And if that's your mum or your sister, you will be invited as a man to have a blood test to see if you carry that gene too. And if you do carry that gene, then you may be at risk of breast cancer and prostate cancer. So these are the main risk factors in the general everybody walking around population. But if you're a black man and you're a descendant from Africa or African Caribbean descent, your risk is not 1 in 8, it is 1 in 4 before you start. Yeah, and the reason why we think is because back in the bad old days, when people were traded as slaves, people were stolen from Africa and shipped to other parts of the world. And most of these people from this particular part of Africa were taken to the Caribbean, and it is their descendants that show the highest risk. This is about the DNA of those peoples and where they originated from in their part of the world. So you can see that we work very hard to reach black men of African descent, because they start with a risk of 1 in 4. Then if you add other risks, age, a relative, and BRCA gene, they have a big risk there. So we try very hard to reach that community. Okay. So some of the things that people worry about with cancer, is there anything I can do better, or is there anything that will help me to avoid cancer, or whatever, things like that? Well, one of the things we can all do is look at our diet and lifestyle. If you had a Rolls Royce or a Lamborghini, or you had the most beautiful, expensive car in the world, you wouldn't expect it to run well on cheap, rubbish fuel, would you? You would put the best you could into it to make it run well. The best oil, the best petrol, the best tires, the best everything. And that's you. Your body is your Lamborghini. And so to run it well, it's important to try to eat well. It's important that the fuel that you bring into your body is as best as you can get, the best that you can afford. So bit of sunshine, avoid processed food. Ready meals are tasty and cheap and quick, but they're not really very good for us, and it's better to cook properly if you can, as often as you can, and get your meals from fresh food. Eat the rainbow, they say. So if it's colourful and it's not been messed with, then it's fresh food. And eat other things as treats. But we all like a few chips or a bit of white bread with, something tasty on it. All those things. I'm not saying don't eat those things, but what I am saying is try to eat as well and as healthily as you can. Not just to prevent some of these illnesses, but also so that if one of these illnesses comes your way, you're feeling pretty healthy in other ways to start with. So if your body's as best as it can be in terms of how it's running, then that will help you to be strong for the treatments that you might need to have. So that would be my advice about diet and lifestyle. Some people like alcohol, some people like a drink or a tipple now and then, just now and then, not all the time, just now and then is okay. So what symptoms might I experience? What might I notice if there's a problem with my prostate? So one of the things is that I mentioned was difficulty passing urine. Do you remember I said if it's getting enlarged, it can be squeezing that water passage? So it might be that when you think you need a wee, you just can't start your wee. You think, well, I thought I needed a wee a minute ago, and now it's taking a while to start. And then it does start, and that's fine. But I never quite feel as if I've emptied. Now, there can be other reasons for that, but this is one of the signs to look out for. If you notice blood in your wee, if you see blood in your wee, let somebody know. Okay. And blood in your semen. So semen is when a man comes. So if you notice specks of blood in that, then also, again, report that to somebody that you trust who will help you go to a doctor about it. There's nothing wrong with talking about these things. This is your health, and it's important that you feel able to share this information with people you trust. But weirdly, some men with early prostate cancer don't have any of these symptoms at all. But fortunately, there are other things we can do to check. So we would be asking you about your family history, all those things as well. But also, we have a blood test as well. So there is a blood test called the PSA test. You might have heard of that. It's in the papers a lot at the moment, and it's in the papers all the time, really. And that stands for prostate specific antigen. So PSA is a protein, and it comes out of the prostate gland, and it mixes with the seminal fluid or the cum, and that helps nourish the sperm and is useful if you want to try for a baby. So that's its job. And so we expect it to be at certain levels at certain ages in your life. So at a certain age, say in your 40s, we'd expect your PSA level to be around 2.5. And then when you're older, sort of 70s up to 80s, it might be 5.5. So we've got an idea of what we expect those figures to be. So a doctor can say to you, well, we'll do a blood test and we'll see what the PSA is. And we'll add that to the jigsaw puzzle we're building up of information about you. The only thing about PSA is it's not 100%. And that's because if you've got, say, an infection in your prostate, or it's inflamed or sore, but hasn't got cancer, that level can rise just because it's all crazy going on in there. And some people don't get a raised PSA at all, no matter what. And although PSA can tell us whether we think you have cancer or not, as part of all of the things I've discussed with you already, on its own, it's not enough. And although it can say yes or no, most of the time, it can't tell us whether your cancer is aggressive or mild. We can only find that out by doing a biopsy, and that would come later. So there would be gathering information. The most effective way on top of all of this as well is for a doctor who knows how to examine a prostate on top of all these other things to have a look at your prostate, to feel your prostate gland. Now, you remember earlier I told you where it was, and where it is at the top of where the urine pee starts to come from in the bladder, and it sits there in the bladder, and you can see the bladder there. But right next to the bladder, if you think about it, is your rectum, and your rectum is where your poo comes from. So they're right next door to each other. So what a doctor can do, and some men think, oh no, I couldn't bear it. But I can tell you, I know tens of thousands of men. That's how long I've been in this nursing, men like this, who've had it done. And they say, actually, in the grand scheme of things, when it came down to it, it was all right. It wasn't that awful. So the doctor will put some special cream onto a gloved hand, and he'll just put the tip of his finger in and just feel for the prostate. And it should feel smooth and it should feel soft. But if he feels nodules or lumps and bumps on it, he's going to be suspicious that there's a cancer in that prostate. And if that feels like that with a raised PSA, and you're sort of in your 50s, and you're having urine problems, and you're having problems coming or having an erection when you're normally okay with that, then he's going to think we need to send this man for a biopsy. And that would be the next step. So what can you do? Well, be aware, you know, if you come from African Caribbean descent, then know that your risk is high. And be aware of your family history. Now, Not everybody knows their family history, do they? Not everybody knows their dad or sees him anymore. Not everybody knows all their brothers or their uncles. So if you don't know who these people are and you don't know what their history is, well, I think that's a strong reason to be even more cautious and say to the doctor, well, actually, I don't know how high my risks run because I don't know whether the men in my family have got prostate cancer or not because I don't know them. So say so and say, I want this investigated, please, because I've got other things that concern me about my prostate. And remember that a PSA and the finger test together can be very helpful. And in the future, we hope that there'll be targeted screening for high risk groups, well, for everybody. Because believe it or not, even though 55,000 men a year are diagnosed, there is no screening program in this country. So you have to take yourself to flag this to a doctor, and you have to know about these things. So if we think about, I don't know if you heard, but Sir Chris Hoy, yeah, the cyclist, fit as a butcher's dog, isn't he? Fit as anything, you know, could catch pigeons if he wanted to. And he just got a pain, I think, in his shoulder. And he thought, I've been hammering it a bit much in the gym. And what they found out was that he had prostate cancer that had spread to his bones. So he had advanced prostate cancer. And then when they looked into it, he had a strong family history and he didn't know he should be doing something about that. And look what happened. So some of this is about us as people knowing, understanding how our bodies work as best as we can. And if we're worried about something, speak up for yourself or for the man you love or the man who's your friend and say, I'm worried about this actually, because something's different. And just a little quick word about treatment. I'm not going into all of that tonight because I don't think that's what we're here to talk about tonight. But what I will say is sometimes, often actually, if you have a prostate cancer that's very slow growing and small and is just quietly there, and that can happen. Lots of people, that's why I was saying to you, you know, there's tens of thousands of people with prostate cancer who are just getting on with their lives because their cancer's slow growing. And if that's the case, then they don't have surgery or any other treatment. They're just watched really carefully. So that's called active surveillance. So they're watched really carefully by a cancer doctor. So they have regular checkups, regular blood tests, regular finger in the bum to just check if anything feels different. And they can also have a test called an MRI scan, and they may just have an occasional biopsy to see if there's any changes. And those men are just getting on with life. And there are other men who may need to have the prostate gland removed. So that's called a prostatectomy, so removal of the prostate by a surgeon, either using a robot, so the surgeon is there, but he uses a robot, or they can have an open one, or sometimes you may need radiotherapy, and other people won't have those treatments. They will just have hormones, and those hormones can stop the symptoms of the cancer. So that's a little window into what the treatments are. So I'm going to conclude the prostate cancer one now. So just to summarize, we've talked about what the risks are, what the signs and symptoms are, what the tests are to look into it, what to expect, how to ask, who to ask, and what the treatments are likely to be. Okay. So, Miriam, would you like me to invite questions after each section or at the end?
I think we should do it at the end if that's okay.
That's okay. So if you've got any questions, folks, keep them in your head. We're going to move on now to the second part. And this
Sorry,
is,
Sinead, I was going to say a couple of, there's already some comments in the chat. So if people want to write them in the chat, then we can just loop through them at the end. So they don't need to
yeah,
worry about trying to remember them as well.
yeah, that's fine. Yeah, I'm not seeing chat, so I'll leave that to you, Miriam, if that's all right. So I'm going to move on to the second men's cancer, and this is a rare cancer. This is something I work with every day and have done for over 20 years. So this one is penile cancer, so cancer of the penis. So if you're not sure what the penis is, that's a medical term for your willy. So everybody has their own name for the willy, and whatever your name is your name. Whatever you go call it is what you call it. That's your business. But I think we all know what a willy is. So doctors call it a penis, and they call it cancer of the penis or penile cancer. Okay, but you call it what you call it. So yes, unbelievably, people do get cancer in their willy, and not many. It's very, very rare. 760 men last year were diagnosed with cancer of the penis in the UK. So if you think I mentioned 55,000 with prostate, 760 with cancer of the penis. So very rare. Less than 1% of cancers in the world. Very rare. I think you can imagine that fairly upsetting and devastating if it happens to you. Most men who have cancer of the penis are over the age of 50, but not everybody. We are seeing men. I know 3 men that I'm working with at the moment who are under 35. So it's not always men over 50, but it used to be, it's something that you would often see in elderly men. So men in care homes or very old men might have it for all sorts of reasons. But now we do see younger people, and we know that it's increasing. Over the years, we're noticing, over the past 30 years since we've been looking at it, there's been an increase of 20%. So what are the risk factors? What do I need to be aware of? Again, some of them you can't do anything about, some of them you can. So if you're over 50, that's one of the risks. But one of the biggest risks is a virus. So a virus is something that we catch from each other. And viruses are usually fought off by our own body. Our body deals with the common cold, doesn't it? When you get a cold, it's grim. We feel horrible. We wish somebody could sort it out. But antibiotics don't treat it because it's a virus. And when it's run its course, it's run its course. And the same is true of the human papillomavirus. And they call the human papillomavirus HPV virus for short. And if you can catch the human papillomavirus by sexual contact with another person, so any sort of sexual contacts, if that person has the HPV virus and they probably wouldn't know they had it, then you wouldn't know they had it either, would you? So you run a risk of contracting that virus. The second highest risk factor is a thing called phimosis. So phimosis is another medical term, and for what you and I would call a tight foreskin. So if your foreskin doesn't pull back, or if it's a little boy that you're looking after, it's your child or whatever, if the man's or the boy's foreskin doesn't come back over the head of the penis, that's called phimosis. And that can be jolly sore and uncomfortable. And it's something that should really be treated when the child is very small, when the boy is small. So usually people notice it when they're bathing a baby or changing his nappy. They think, oh, I can't clean under there. That's a bit tight, or the baby might be a bit, don't touch me. So that's, you need to get a doctor to look at that. Now, some people, nobody notices it, either because they've been in care, or they've been in hospital a lot and nobody's really taken any notice of the willy in that way, or because they've had nobody to tell, so they've kept it private. So if you've got a painful willy and the foreskin doesn't come back, you can get infection under there, and you can get redness under there, and that can cause you problems. And that problem can sometimes trigger a change in the cells in your penis that can become cancerous. Okay, so what we suggest, if you have a phimosis or a tight foreskin, that your doctor does a circumcision. So removes the foreskin. So circumcision is what some little boys have when they're born because of the religious beliefs of their family. So you'll have heard of it, I think. So they'd snip the foreskin away. Doctors do it all the time. It's done as a day case. It's something that you can have done if you're a man or a teenager or a boy or a baby. If you can have that done. If you have that problem, just don't put up with it. Another issue is smoking. Big bad smoking, we know it creates chemicals that are poisonous to the body and cause all kinds of cancers. So please don't smoke. And while I'm on about it, please don't vape either, just because I'm on my hobby horse. And you're only swapping one baddie for another. Get rid of it. And some people have another virus called the HIV virus. And these people their immune system is so compromised that they run the risk of all sorts of other conditions. And penile cancer is one of them because they're vulnerable. So what to look out for? Redness, a rash, an ulcer. So an ulcer is like a ready, sore, wet, painful, lumpy, bumpy on your body. Sometimes you get them in your mouth. If you've ever had a mouthful, you know how awful they feel. Well, you can get them on your penis as well, on your willy as well. So you might notice one of those, or a lump. And you might only see the tip of the iceberg, but a doctor will be able to examine and see how deep that lump is going down. Anything abnormal, bleeding, changing the way your water sprays, just something different, something that wasn't like that before. Don't get used to it. Don't say, well, that's just me, or say, doesn't really hurt now, so I won't say anything. Don't ignore anything like this. It's important. So awareness, who do you turn to? Who do you ask? How do you get to know? I've got something going wrong down there. Go and see your doctor. Ask to see a doctor about it. Now, to be honest, some doctors don't recognize it either because they don't see it very often. But if you've got something that's not healing on your penis, on your willy, and it's causing you problems, all the Canesten and Sudocrem and all the everything under the sun will not make it go away. It might make it less painful if it's painful. They're not always painful. But if it's painful and it makes it not painful, doesn't mean it's treated it and cured it. Penile cancer, cancer of the willy, will not get better on its own. If you're not happy, speak up and tell them it's still the same. So the next step is that you need to see a waterworks doctor. A waterworks doctor is called a urologist. So think about urine. A waterworks doctor is a urologist. That's the next step. And sometimes you might have to speak in your strongest, loudest way to say, this is not getting better, doctor. I don't want to wait. I want to see a urologist. And I know all the urologists in the UK, and they all say they would rather see 10 men who didn't have it in the end than one man who waited too long. So don't be afraid to speak up for yourself or the people you care about. So the treatment options, sometimes if it's very small and minor, they can take it off with a little laser. They can take it off with dry ice stuff. They can do special chemotherapy creams, so not creams you can just get, special creams that are prescribed by a doctor, a cancer doctor. But an operation is the most likely treatment. And you can have chemotherapy and radiotherapy. So the sooner you act, the more likely that you'll have minor issues and less troublesome treatment. So please seek medical help early. Okay, so that completes my presentation about cancer of the penis. So again, if you've got any questions about that, if you've put them in the chat for Miriam to see, and we can look at them together at the end, or just ask me at the end. And so I'm going on to the third part now. This is the final part. This is the third cancer that only men can get. And this is testicular cancer, cancer of the testicles. So your balls, in other words. Doctors call it testicles. Most men just call it the balls. So that's the part of you I'm talking about if you're a man. So not hugely common, thankfully. Around 2,400 young men will be diagnosed with testicular cancer every year. Nearly half will be under the age of 35. This disease most commonly affects people from the age of about 15. So from puberty up until the age of about 45. And then I was going to say if I had one on me graph. So it trails off as you start to get older. 95% of people with testicular cancer do well and recover. But sadly, like Colin, I mentioned Colin, who thought it was the end in 1995. But sadly, around 60 men every year will die of testicular cancer. It is very treatable, and we have the treatments that can do it, but it needs to be found and mentioned early. As soon as you find something is wrong, that's key. It seems to be the same message for everything, and it is. So here's me graph again, if you're interested in graphs, which I'm not. There they are. So you can see how low it is. If you're a younger man, the numbers are very low. If you're around sort of 10 to the age of 14, there's virtually nothing. And then as you start to get a bit older and you start to get to puberty and into adolescence, and then into your 20s and 30s and into your 40s, and then it starts to go back down again. You just don't really ever see it newly diagnosed in old men. So if you think about these men, most of them some might still be in high school. Some will be at uni if they're the type that went to uni. Some might be just living away from their parents for the first time. Some might have just fallen in love. Some might be traveling. They're just on the cusp of getting on with life, and then this illness can happen. And when you're busy like that, you might not always be keeping an eye on yourself. And so this is why we want you to understand the signs and symptoms and the things that can create and raise your risk. So apart from your age, one of the main risk factors is an undescended testicle. So if you were born and one of your testicles hadn't come down, they usually come down just before you're born. And they come down into the ball sack. And if they haven't, a doctor will usually notice or be told, and they can release it for you if it hasn't come down. But normally it makes its own way down before the age of 1. But if that's happened and that's in your history or in the history of a young man you know, then keep it in mind throughout his life because we know it can increase his risk. Again, back to family history. If your father had testicular cancer, your risk increases by ×4. But if it's your brother who had cancer of the testicle, your risk increases by ×9. So that's significant. So if one boy in the family gets it, the other boys in the family have an increased risk, a very significant increased risk. And, I mentioned the undescended testicle. So something not right with the testicles, sort of something always going on with them or not, not functioning normally, something of interest throughout the developing years of that young boy, can be signs that there might be something going on that may show as cancer later. So back to what I said earlier, if you don't know your family history, if you don't know your brothers, half brothers, step brothers, sorry, not step brothers, half brothers, brothers, and your father and your uncles, then I would say if you had an undescended testicle and any other issues, that you need to say to your doctor, I don't know whether I carry a high risk, so I'd like you to consider looking into this with me, please. So some of the things that they say that might be other reasons why people get testicular cancer. Some studies in America seem to indicate that very tall men seem to be somewhat more likely. It's a very small study, but it's a study, so I've mentioned it here. And if you have HIV, I mentioned that earlier as being that, something that makes people at risk of all sorts of cancers. So if you have HIV, you are 3 times more likely than not to get testicular cancer. It's particularly prevalent in white men. And one of the things that they sometimes suggest as being a risk is, have you had repeated trauma to your balls? So do you play rugby? Do you do kickboxing? Have you come off your bike onto your crossbar? Have you had a kick in the balls? Something repeatedly that has damaged or hurt them. Keep that in mind. And also when people go to the gym and they get these unlicensed, illegal bodybuilding drugs. So they're going to the gym, the bodybuilding, they're doing the lifting, they want to look bigger, they want their arms to look great or their legs to look great. And there's always some bloke in the gym who will sell you stuff. It's not licensed. We don't know what's in it, but the chances are there's some sort of hormone in there that could wake it up. So for all the other reasons, stay away from it. But this is a big reason to stay away from that kind of stuff. He might be a nice, charming guy who is doing you a big favor at the gym, or he's not. If you're going to get bigger properly by doing the exercise and the work. And also, we are noticing that since marijuana has become declassified as being almost not taken that seriously anymore, and more people are using it, the rates are going up. Again, because you don't know what's in it. You don't know where it's been grown. You don't know what it is, and the issues that it can bring to your body and cause problems for you. So what are the symptoms? So any change in your balls that you think that wasn't like that before. Some people often notice a lump or a bit of a hardening. And unless you examine your testicles, you're not going to know. So I would say, get to know them. I'm going to talk about examining them in a minute, but, it's your body. I know we like to be private and people say, what you doing? But when we're in a bath or a shower, we're having a wash and, we'll have a little check around and and, often regular, and say, well, what does it feel like today? Does it feel like it did last time? Or I've got a bit of a soreness going on, a bit of a pain, a draggy pain. I'll just have a feel of my testicles and see, is there anything in there that's different? So a hardening, a swelling, heaviness, a feeling of, God, it's dragging. It's a bit hurty. And sometimes, and it's really rare, and I'm just going to mention it, but sometimes people feel that their breasts, and men do have boobs, don't they, as such? You have that bit where the nipple is. But if that feels a bit tender, I'm not going to go into why, but if you notice it with other things, then mention that too. Mention that as well. Now, there are lots of things that can cause lumps and bumps that aren't cancer, so don't panic. So you can sometimes get a swelling called, it's got a big long name, so I'm going to go for it, epididymoorchitis. So basically a swelling in the testicle to you and me, and it's not cancer. Just get it checked. Sometimes you can get water-filled little cysts in there. The doctor will examine it and say, I think that's just a cyst, we won't worry, but we'll have a look with an ultrasound scan. An ultrasound scan is just where they put gel on it and just rub a thing, and you can see on the screen, and they can say right away that, no, that's just a water-filled thing. Or just a varicocele. So that means to do with veins. So you might notice the veins on your testicles, on your ball sack come up. But again, that's not testicular cancer either. And again, looking out for fluid-filled sacs or cysts or things like that. The doctor will be well used to feeling those. So as I said to you all the way through, anything new, anything different, report it. Let the expert have a look. Let the expert tell you. And if you're not happy, ask him again. So the key to this is examining your testicles. So like I said before, it only takes a few minutes, and you can't get told off if you're examining them for health purposes. So when you're in the bath or the shower and you're feeling relaxed and warm, just have a little feel. And what might you feel? Well, the normal thing that you'll feel, just forget all those words and all those other bits, is just that front bit there. That's the testes, and then you'll feel a thickening just behind it. And that's what you need to be feeling around for. So anything that's different to that or new and doesn't feel like that, and it's tender or sore, then have a chat with somebody about it. It's normal for one side to be bigger than the other. So one ball will look bigger than the other. That's normal. But you'll know that because you'll know what yours look like. But if you don't, or you can't see them very well, and somebody else is helping you with your washes or your shower and everything else, then it's important to point out that it's important to me, in my case, that somebody is keeping an eye on my testicles and keeping an eye on my penis or willy to make sure that there is nothing new happening down there. And that you expect somebody to take responsibility for that and help you with that. Now, that might mean regular visits to your GP. If you've got carers who say, well, I'd rather not, then, well, that's not good enough. Then it needs to be somebody else. And don't be afraid to ask. Doctors don't care. It's just another part of the body to them. So say if you have got a testicular cancer, what happens? So they do that ultrasound scan that I mentioned with the gel and the little thing that they just rub on. It doesn't go in anywhere or anything. And if they say, yeah, that we think there is a cancer there, we need to remove it. What they will do is remove just the testes. So I've got like a little picture here. So you can see the one down here, there's the testes and there's the tube that I showed you on the other picture. And that one's fine. But the other one, you can see there's a bit of a lump on it. So it's been decided that this one needs to be removed. So how do they remove it? Very simply, they make a tiny little nick in your groin. They don't touch the ball bag at all, or the penis, the willy. They don't touch any of that. They go up into the groin here. They make a small incision, a small operation, and remove it. Close up the little cut, and then that's it gone. And it gets sent to the lab to be double checked. So what will that mean for me if I've got one not there? Well, it doesn't affect your fertility. If you would like to have a family, having your one ball removed doesn't affect that. You're no less the man because your libido and your sex drive and your urges are the same, because your other ball is producing enough of the hormone called testosterone that you need to keep all that going. And if you don't like the look of it, they can put a false one in when they take yours out. Or if you're not bothered at the beginning and then you change your mind, they will do it for you later. So it's entirely up to you. Everything carries a bit of a problem. Some people say, I don't like the feel of the false one. I'm not that bothered. Some people say, well, it's important to me to look the part, so I want both, please. It's your business, you decide. So remember, examine yourself regularly, or get somebody who's caring for you and knows your body well to do that on your behalf. If you're not happy and you're not sure, get an appointment with your doctor. So we know that sometimes when you ring up, you might not get the doctor. You might get somebody else, a different member of the team. For this, I would say, I have a lump in my balls. I want a doctor, please. I don't want to see anybody else. And like I mentioned earlier with the ones on the penis, if you ring them and say, I've got a bit of a rash, they're going to just give you Canesten. So I want to see a doctor about my penis today. I don't want to see the district nurse. I want to see somebody more senior in the team. The quicker you act, the less treatment you may need, because removing the testicle is the first thing that they do and is often all they need to do, but some people do need chemotherapy. And the sooner you act, the less treatment you're going to need. And please remember, 95% of men are cured. So don't be embarrassed and don't be daft about it. Oh, I don't want anyone looking at me or touching me down there. If it's a doctor and he knows what he's doing, bring someone with you to be with you. If you're worried, and find out what's going on. It's probably nothing, but sometimes it's something. So don't delay. So move more if you can. Try and have a good diet to get your body into a good physical condition. Get a bit of exercise. If you want to talk it through, you can. There are people you can talk to. You can talk to people at my charity called Orchid. We offer counselling. It's free. It's on the phone. You don't have to wait long for it. Just let us know that you would like to do it. This is the phone number. Miriam's going to share this properly and put it on for you. But this is a free phone number that you can ring, and you'll talk to either me or the other nurse called Rob, depending what day of the week you're in, because we share the work. And from that, we can have a good chat about it as many times as you want to, about any of these three things, or any of these three things if you're worried about them. And if we think you need to, and by we, I mean you and me, or you and Rob, think you would benefit from it, we will organise for you to see one of our counsellors. And there is no big waiting list, and there is no charge. So you can have up to 8 sessions with a counsellor if you have cancer of any of the 3 types we've discussed tonight. And that concludes the presentation.
Thank you so much. It was fascinating. I have learned rather a lot that I didn't know. And I just want to, again, thank you very much for the education, for the clear and you know, caring, but also just matter of fact way, because that's basically how we have to deal with these things. So
Yeah,
um,
yeah. And sometimes I might say balls or I might say willy or whatever, and that's not to be vulgar or coarse. It's because we don't always use I use medical terms because that's my job. But I don't know any of the proper terminology for other people's jobs. So I'm happy, to say what we say here, and as long as I'm not, just being cheeky about things, because
no,
most people
absolutely.
do say willy or balls, and
Yeah.
that's why I do. But um, it's nothing to be, it's not dirty, it's not nothing to be ashamed of. It's private because we are all brought up, I think, to believe that these things are private, but they're not secret.
Mm, mm. No, I really appreciate that. So I think now we're going to go to questions. I'm
Okay,
going to start with some of the ones in the chat before I open up the floor. Um,
okay.
and Rachel had a couple of questions. So the first one was, does a physical disability or any type increase a man's individual's likelihood of getting a cancer diagnosis?
Of these three cancers.
Hmm.
Yeah, no.
Brilliant. That was clear. So it doesn't
It,
make you haven't got an increased risk if you have a physical disability, which is
no,
really good to
no, but
know.
you may have risks associated with that disabilities, such as not be, it just such as maybe you don't move around as much as you would what other people, or maybe you have to be a bit more careful with your diet if you're
Right.
not moving around a lot. So remember, I suggested that you need to be make sure that you don't eat too much junk food so that you don't get fat. So that when you're if you become ill with something like a cancer, you're fairly healthy in other ways before you need treatment. That's
Yeah, so there's those associated things with being
yeah, but yeah,
sedentary, so not moving around much. But then I suppose that there are other people that don't have a physical disability who also,
exactly.
yeah, that's fine.
Exactly. So it's not the physical disability that I'm linking it to. I'm just saying that maybe for all sorts of reasons, people who aren't able to move around as much or have as much say about what they're eating
Mm.
for whatever reason.
That makes a lot of sense. So
Yeah.
then another question is, does an individual's ethnicity increase your chances of cancer diagnosis for all cancer types or only the male ones?
Um, Not all cancers, but some. There are some ethnicity issues linked to some of the cancers that women can get as well. But I don't talk about those in this talk. But certainly, like I mentioned, um, men of African descent, or African Caribbean descent, need to be really switched on to prostate cancer.
Excellent. Um, and I wanted to ask about the PSA test.
Yeah.
Is it is it reliable by itself, or do you normally have it if you have other symptoms?
Um, I mean, they tend to sort of say, doctors can sometimes be a bit reluctant to do a PSA test. Men go in and say, I'm a man of a certain age, I'm having a few waterwork symptoms, I'd like a PSA test. And doctors, Matt, will sometimes say, oh, I don't think we've got enough reason here. Oh, there's no, and some people are saying you don't need to have the finger in the bum test if you don't want. The PSA is enough. Well, we know enough about other issues to think that that's not really a safe way to go forward. And we work with the European Association of Urologists, so the waterworks doctors from all around Europe. who deal with prostate cancer are saying the PSA test on its own is not enough.
So I suppose what I'm wondering is that if you don't have any other symptoms,
Yeah,
is it okay still to say to go into your doctors and say, I'd still quite like one?
yes, it is.
Okay.
Yeah, and remember, if you need to, you know, add add weight to that conversation, you can say, if you know your family history, what your family history might be, if it's pertinent, and if you don't know, then mention that, and just say, I know that one of the um one of the main factors is age, and I'm of an age.
Mm-hmm. Mm-hmm. That's really,
Uh,
really helpful.
it's
Um,
not an expensive test, so it won't be that your doctor's being mean about it. He's probably thinking, let's not open up a can of worms for no good reason. I'm thinking if somebody'd opened a PSA can of worms for Chris Hoy, I'd be feeling a bit different today.
yeah, yeah. Especially as it is literally just that test.
Yeah.
Um, how does it affect people when they do have their prostate removed? What is the effects of that?
Okay. So do you remember on that picture I showed you how close it was to the penis, the willy, the bladder, and right next to the rectum where the poo comes from? So all of that area um obviously has is close together. And it's not as it's all close together, all near each other, and all um, connected by similar nerves. So some of those nerves might already not be working fully for some people, and they may need a catheter or do self-catheterization, or they may need help to pass their poo or whatever. And that's because of all sorts of other reasons. And some people may have problems with erections, that they find that they can't have an erection or they can't come, and that can all be to do with the nerves or lots of other reasons. When you have the prostate gland removed, because of the closeness of all these other places, one of the side effects is that some men struggle with urinary incontinence.
Right, that makes
So
sense.
some men, even for a while,
Mm.
may leak urine
Mm.
a lot in the beginning. So they might need to wear a pad all the time in the beginning while the body gets over the shock. And then maybe later, just say if they do a big cough or something like that.
Mm.
So, and do you remember I said if you've got a small, low growing prostate cancer, they'll leave it alone? That's
Mm.
one of the reasons why.
Mm. That makes
Um,
sense.
Yeah. So when you have the surgery, it can impact on that, and it can impact on erections and things like that. And that's why, if you are having the surgery, it might be best to ask to have your prostate gland removed by the robot,
Mm.
because the robot prostatectomies are better at preserving those nerves.
Wow, excellent.
Radiotherapy to the prostate gland can sometimes hit the bladder as well,
Mm.
or pass through and hit the rectum as well. So people, when they're having radiation to their prostate, can sometimes have pain and get the runs, and trouble with the waterworks while they're having the radiation, just because of how close things are.
Mm.
So you can see why I keep saying the sooner you go, the
Yeah,
better.
amazing. Thank you.
Okay.
Paul, would you like to ask your question?
Yeah. Are we still recording?
Well, we don't need to. I can
Okay.
I can stop it before then.
Okay. I'll cut it or whatever.
Yeah.
If you've had you frustrate the blood test and then the examination and everything was normal, how often should you go for that check?
That's a fantastic question. It really is. So if I would say sort of as you yearly,
Right,
but before that, if anything interesting happens and you think, actually, I'm not going to wait for the year, I'm going to go back.
right,
Something's changed, watching out for something different, something's changing, or out of the blue, your brother just tells you he's got it. So all of a sudden, your risk increases, so you're interested in
right.
going a bit more soon.
Yeah. Okay.
Thanks,
But
Paul.
Thank you.
yearly in general is enough. Yeah.
So
Thank you.
I was just thinking about the penile cancer that you were talking about, and
Yeah.
I noticed that you talked about the HPV virus.
Yeah.
So I know that young teenage girls have the immunization for that to help
Yeah.
cervical cancer. I was
Yeah.
just whether boys have that at
Yeah.
teenagers as well.
So not initially, weirdly, they just gave it to girls, but they now do give it to boys in most areas. If you've got a teenage boy and they're not giving it, ask for it. They should have it
Mm,
because these are the boys that the girls are having intercourse with, and
mm,
these are the boys who are having sexual relationships with one another if they're gay.
mm,
So they have absolutely the same right to be protected
mm.
from the virus because the virus is thought to cause, let me look at my whiteboard, excuse me, let me look, 63% of penis cancers.
Wow.
Mm,
Okay. That's amazing.
yeah,
Okay. And then moving on to the testicular cancer, I think there are
yeah,
some really interesting questions around assessment and screening. So it's a little bit like, women have learned to, how that they need to examine their breasts
yeah,
and how to do it. And if you can't do it, who can do it, etc., to help you.
yeah,
So I suppose
yeah,
it's very similar mirroring to examining, everything down there. And
yeah,
if you're somebody else, Katie, also mentioned that most doctors you can book online, if you don't really want to speak about asking for the appointment, um,
yeah.
and so you can either have your carer or your GP. But I was curious, on the website, is there any like tips like you've got for the breast cancer, how to do it? Is there tips onto how to do it for your testicles?
On our website, yeah.
Yeah.
Yeah,
Okay. So
so just
that's a
if you
really
just
great
go onto
resource.
just go onto the Orchid website and go to information and support, and
Mm.
then click on testicular. Well, all three are there, but if that's the one you're interested in, click on there. And if there's anything you're not sure of, just ring that free number and one of us will talk you through it.
Amazing. And then I suppose if you are, where is the boundary between, if you want to have that done, and you have carers, is it up to if you want to put that in your care plan, so that's
Yeah,
part of your general maintenance, that
yeah.
maybe every year or something. I'm assuming that if not all carers might be comfortable to do that, so that's absolutely.
Adults, yeah. I think you're right, Miriam. I think some carers would feel the weight of the responsibility for that. So it's got nothing to do with dealing with somebody's intimate care. It's to do with what if I miss something important? I'm not a doctor. I don't think it should be on me. Um, so I think there's a conversation to be had
Hmm.
for people, to support people who are not able to do those examinations for themselves. We need to be asking the questions. Well, who will then?
So I suppose, in a way, in the care plan, if the person wanted to make sure that they have that yearly sort of check for peace of mind, that they could maybe say either with the carer or a GP, but that however often they want to have that reviewed, that it's in their care plan as part of the plan for their own self-care.
Yeah, but if you're a person over the age of 14, then somebody needs to be looking after the examination of your testicles, and that needs to be done regularly.
Right.
So much more regularly than that. So, I'm not going to say once a month or whatever, because I don't think you can set a calendar to it, but it needs to be done frequently and regularly so that the person examining or the person reading the care plan where the previous person's documented it can say, well, nobody said anything about that last time it was this man was examined. Or it might be that the man says, actually, I'm a bit tender down there, so I need an extra check. And when that, so there needs to be that provision in my view for all men over the age of 14, because that's what that graph showed us. That's a national statistic. We know, well, it's probably worldwide actually, but we know that that's the increased risk. And if we know of the other increased risks in that person's case, then we can make an even stronger case for why that should be happening.
Brilliant. That is so insightful. Really appreciate that. One last question. If you're out of the teenage years and you still want to have an HPV vaccine, how does one go about that?
So I think your first step would be to ask the GP's advice on what's happening in your area. So your primary care network, how they do it. And I think if all else fails, there would be some provision to get it done privately, I'm sure.
Right. That has sorry.
It shouldn't come to that. Why should it?
Well, no, absolutely. I think that what's fascinating, having done the Women's Health Month, a while ago, that there are so many parallels for for all of us from a health education point of view. But I also think that it just highlights, like for some of the screening for women, that there are just as many challenges when you have a disability. For screening for some of the men's cancers.
And there's just this whole thing around the intimate nature of those parts of the body. Fine, fair enough. So most people, could probably say, well, I'm able to do that for myself. Most of them don't, even though they can. But if you can't, and for whatever reason that your disability precludes that, then there has to be facility within the system for that to happen.
Yeah, absolutely.
Nobody's going to let you develop tooth decay, I would hope, or any other kind of issue or cancer. So just because it's below the belt and a bit private means, in my opinion, that you should be even more thorough and careful in the care of these people who rely on others.
Brilliant. Just for everybody, if they want to take the note down, I've put the helpline number and the email address in the chat. I will, and if you Google Orchid, it comes up, or Orchid cancer, it comes up at the top.
So if you Google Orchid cancer or Orchid men's cancer, then you won't get a gardener telling you about Orchid the flower, which is a bit weird. And the reason why we're called Orchid, just in case you're wondering, was, do you remember Colin, that first patient who started this charity off? Well, his was in his testicle, and in surgeons call removal of the testicle orchidectomy.
Makes
it's
sense.
Latin or something. So that's why we were stuck with that name, which we're constantly explaining. Because people say, why are you named after a flower? Well, we're not, but it's a long story. So so if you're Orchid men's cancer or Orchid cancer, you'll get ours. So there's little videos on there. There's men on there talking about their experiences, little films. on YouTube and different things that are real men, real people who've experienced these cancers, who are happy to talk to to other people on there and do their little recording.
Thank you so much, Sinead. It is